You're listening to the Addiction Medicine Podcast, the official podcast of the Governor's Institute. If this is your first time listening, thanks for joining us. The Addiction Medicine Podcast is designed for healthcare professionals and others interested in addiction medicine and will feature thoughtful conversations and insights from clinicians, patients, and families, policymakers, and other stakeholders. Remember to make us a favorite wherever you get your podcasts. You can also stay connected with us at governorsinstitute.org or follow any of our social media channels at @govinst.
Hi, I'm Alex O'Neill, Project Coordinator at the Governor's Institute. The fourth episode of Season 2 of our Addiction Medicine podcast looks at some unusual and interesting cases in addiction medicine. We were excited when Dr. Edwin Salsitz signed on to be a speaker at our 2022 Addiction Medicine Conference. Dr. Salsitz has been an attending physician in the Mount Sinai Beth Israel Division of Addiction Medicine in New York City since 1983 and is an associate clinical professor of psychiatry at the Mount Sinai School of Medicine. He's a course director for the American Society of Addiction Medicine, sponsored buprenorphine and risk evaluation and mitigation strategies, save opioid prescribing trainings. Here is Dr. Edwin Salsitz with interesting cases in addiction medicine.
I see some friendly faces in the audience, Shannon Miller and Steve White in the back. So let me thank Jim Finch for inviting me. And let me also thank Colin Williamson and Jeremy Kroom for helping me with a lot of logistical problems and the slides, et cetera. So I'm doing this plenary session on interesting cases. And I timed it for about a 45-minute presentation, so I might end a little bit early. And then I'm doing a workshop following this with other interesting cases. And in addiction medicine, I think it's generally true that there isn't usually that much of a differential diagnosis as there is in the other fields of medicine. We usually kind of know what the drug is and if it's withdrawal or intoxication. But every now and then cases come along that are a little bit more interesting, and I try to collect them and put them together so they can be presented in an interesting manner. I always like to start with this slide, which I got from a colleague called Timothy Wiegand. All things are poisons, for there is nothing without poisonous qualities. It is only the dose which makes a thing a poison. And this was said by a physician 500-600 years ago. And when you think about it, all of the drugs that we talk about, opioids, benzos, cocaine, nicotine, it really is the dose that makes the problem. These drugs are not inherently good or bad. You know, it's how they're used and the dose. And you'll see why this is pertinent as we go along. So we don't have an audience response system, but there'll be opportunities for you to respond and see what you think. So the first case is a 24-year-old male, and your job is to name the drug. So this is a 24-year-old male admitted to our inpatient rehab for substance use disorder of intranasal use of X drug. He lives at home with his father and sister. Mother died when the patient was 21 years old. X drug use started recreationally at age 20, quickly became daily episodes of using and not using and relapsing. The drug use is limited only to X drug. Medical history is negative except for many urinary complaints, frequency, hematuria, pain. He's had similar symptoms in the past, no discharge or penile lesions, sexually active, heterosexual, HIV negative, smokes a pack of cigarettes a day. So on his urinalysis, he has white cells, he has red cells, he's positive on the leukocyte esterase test. His urine culture, though, is negative, as is his comprehensive metabolic profile and his CBC. The urine drug test that we had at the time, we have a much more expanded one now, was negative for the usual suspects. His GC chlamydia and RPR syphilis tests were also negative. So does anyone happen to know what drug this is? Well, not you, because you've heard it before. Yeah, not you. Okay, so that's good. I mean, I always like it when people don't know the answer. When people know the answer, it's not as much fun. But if you were into this, if you were on the right track, you might say, well, what about his ethnicity? Maybe that might help me. And he's Chinese American. So I don't think that's going to help you in the room here, but it could help you. And what this is a classic case of ketamine cystitis, which of course I never heard of until we had this case. Now, in the literature that comes out of parts of Asia, almost every article in the urological journals is about ketamine. You can see here it says ketamine cystitis, its urological impact, a murderer of young bladders, ketamine-associated cystitis. And then the last one is an article that discusses the mechanism of how it causes it. So who knew this, that ketamine is the most common illicit drug in Taiwan, Hong Kong, Singapore, or Malaysia. And I'll say that this was true at least 3 or 4 years ago. I haven't been able to get updated data on whether that's still the case. And it presents itself with frequency, urgency, suprapubic pain, dysuria, hematuria, gross hematuria, microscopic hematuria, and you get ulceration of the urothelial lining of the bladder, inflammation, and as it goes on, you get more and more fibrosis. This happens in about a quarter of regular users. It's dose and frequency related. Male and females, same incidence. The pathophysiology is not well understood. Some sort of local bladder irritation, some autoimmune phenomenon or vascular damage, and you get sterile pyuria where you have the white cells, but you have a negative urine culture, you have decreased bladder capacity. The only treatment that really works is to stop the ketamine. Other things that have been tried are this hyaluronic acid, chondroitin sulfate, and the botulinum toxin. You can give them comfort meds, NSAID, steroids. That's what we gave them. They plus minus work. And if this goes on long enough, the bladder becomes very, very small. And I'll show you a slide of that. And you have to do a urinary diversion where you have the ureters coming out and into a bag, or some sort of augmentation cystoplasty. So our patient improved over 1 week. We gave him some urological follow-up. I've tried to call him and stay in contact, but I haven't been able to get a hold of him. So for you folks who are a little bit older like I am, this was called an IVP before CAT scans came along. And what this shows, let me see, does this have the point? It does have a pointer, right? Yeah. I got to do it over here. Yeah. So this shows hydronephrosis, hydroureter, and this very, very small shrunken bladder. This is after years of ketamine use. So this is the end stage of ketamine cystitis. So this case, I remember, came in on a Friday, and the PA who was working in the hospital at that time called me and said, "Do you know anything about ketamine causing problems with the bladder?" And I said, "No, I never heard of it." And she said, "I vaguely remember something about it." And then you go to the NIDA fact sheet, which they have on almost every drug, and there it says that it can cause bladder problems and urogenital problems. So the information was there, I just never knew about it. So since that case, we've had 2 additional cases. The next one was a Chinese American female, same thing, intranasal ketamine since age 18. Dysuria frequency, I mean, these people are literally urinating every 10 or 15 minutes, wearing diapers, uses illicit buprenorphine sometimes as an analgesic. She understands that the problems are due to ketamine. Many friends have the same issues. She left AMA. And then the last case was a Greek-American female, not Asian, intranasal ketamine, again, part of the club drug, and then became more intranasal ketamine. The primary drug along with intranasal cocaine. Drug dealers, primarily Colombian, friends who are users of Caucasian Hispanics, has had intermittent dysuria and frequency. Right now, a normal UA knows the connection between intranasal ketamine and urinary symptoms. And now I'm going to give you a pearl that when people use ketamine and cocaine, that's called a Calvin Klein on the street. Okay. So Talking about ketamine from the abuse point of view, these are some of the effects of ketamine: this dissociative drug, sensory isolation, and some other signs and symptoms. I was a big fan of Dexter. I don't know if any of you were fans of Dexter, but I was a really big fan. And I never knew really what he was injecting. And it turns out that in the initial Dexter, which ran for so long, he was using a opioid called etorphine, which is a very, very potent opioid, 1,000 to 3,000 times that of morphine. But if you watch the latest season with, I think it was called New Blood, they mentioned in the season that he was using ketamine to inject his people in the neck. If you don't know what I'm talking about, I'm really sorry I brought it up, but I'm a big fan of Dexter's. And what's interesting about ketamine is depending on the dose, you get different effects. And I know you all know that it's being used therapeutically now. And is that the next slide? No. Here's something else that's interesting. Ketamine is a cousin of phencyclidine, and it's also a cousin of dextromethorphan. And yet those two molecules, phencyclidine and dextromethorphan, have never been reported to cause cystitis, even in heavy users of those two sort of congeners of ketamine. So that's an interesting fact. And you know that ketamine is being used. The FDA approved a nasal spray of S-ketamine, one of the isomers of ketamine. It's highly regulated, and it's got to be given in doctors' offices, and it's very regulated. But a lot of psychiatrists and maybe others have set up ketamine clinics and are doing IV ketamine for depression. And whether that's good, bad, or neutral, I actually don't know. Huh? There's one in Asheville. They're popping up all over the place. So that was ketamine cystitis. Interesting disease. Next case. So the next case is a 64-year-old female admitted to our rehab for treatment of alcohol use disorder following a detox protocol. She's been on methadone for many years, 60 milligrams, and her opioid use disorder is in remission. She's married. Her spouse has no substance use disorder problems. She's got a little bit of a family history with her father and her couple of sisters positive for alcohol. She has 2 children who don't use alcohol. She's a high school graduate. She's employed in sales. And up until the age of 56, she was a social, occasional user of alcohol, wasn't a big deal. Then an event occurred when she was 56. And after the event occurred, over a 1-year period after the event, her alcohol use increased to where she met criteria for alcohol use disorder. Her physical exam at this time was unremarkable, labs were normal, and her urine drug toxicology showed only methadone. Now, a 22-year-old male admitted to the rehab again for alcohol use disorder following a detox, negative family history for alcohol. He was a stutterer from age 8 to 14. He was physically abused, he said, by his step-parent, has an associate degree. He was, as a teenager, an occasional user of alcohol, not a big deal. He had an event occur, same event as the woman, same event. And after that event, 2 years after the event, he had increased his alcohol consumption and he met criteria for alcohol use disorder. So your job is to name the event in this particular case. 9/11. Huh? 9/11. No, well, 9/11 was horrible, but no. Huh? A death in the family. So these would be these dysphorogenic kind of things that would happen to people. No, I'll tell you, you're gonna like this one. This is a good one that we should all know working in the addiction field. You ready? Bariatric surgery. So we had a winner? Oh, I didn't hear it. I'm sorry. I'm a little hard of hearing. Sorry. We have a winner. Okay. What does she get, Jim? Figure that out. Okay. So back to the 56-year-old woman. She had bariatric surgery at 56. She had a BMI of 41. at that time. And if you're into this, you're going to have to say, well, what type of bariatric surgery did the person have? Was it a Roux-en-Y bariatric surgery, a sleeve gastrectomy, or a laparoscopic gastric banding? And we'll come back to that. In her case, it was a sleeve gastrectomy. Her current BMI is 24, so it worked well in terms of the obesity problem. She drinks 2 liters of vodka a day at the present time. Back to the 22-year-old male. He has been overweight for most of his life. He's been teased about that. He had a BMI of 41 as well when he was 16. He had the surgery. He had the Roux-en-Y gastric bypass. Coincidentally, his mother had it, the same surgery 6 months earlier. At age 20, he was feeling depressed. He started to drink alcohol, and the alcohol felt much different than prior to the surgery. And now he drinks a liter of bourbon a day, he says, and he didn't lose much weight. His current BMI is 37. He thinks that alcohol is substituted for food, the idea that one addiction is substituted for another. So a little bit about bariatric surgery. I can't read the numbers here right now, but from 2011 to 2018, they went up dramatically. I just can't see the numbers from here. It turns out that 80 to 85% of bariatric surgery is done on women, only about 15 to 20% on men in the United States. So here is the Roux-en-Y surgery, and I got to do it up here. Here's the Roux-en-Y surgery, which, all right. So what they do is they make a very small gastric pouch, and the rest of the stomach is bypassed. And the jejunum is hooked up to that gastric pouch, and the duodenum is bypassed, although the pancreatic and biliary secretions still go in to the bypassed duodenum. It's called a Roux-en-Y because the doctor who did this, his name was Cesar Roux, and the Y is the hookup over here. So that's the Roux-en-Y, and that bypasses the stomach completely with a small gastric pouch. The sleeve gastrectomy, which is the most common, the sleeve gastrectomy, which is the most, I'm sorry about that. The sleeve gastrectomy is the most common procedure now in the United States. And that just takes out a chunk of the stomach and actually takes it out. Here the stomach is left in, but here it's taken out. And so you have a much smaller stomach. The gastric banding just goes on top of the stomach where the esophagus comes in, and it's adjustable with a port where you can make it tighter or smaller. It makes it a little bit more difficult to eat a lot. But the important part to understand here is that the Roux-en-Y and the sleeve gastrectomy bypass a lot of the stomach. So here is a study with 19 folks who had a Roux-en-Y gastric bypass. They were able to look at them pre-op, 3 months and 6 months later. And at each time period, they gave them 5 ounces of red wine, same amount of alcohol. And the pre-op level of alcohol got to about 20. Boy, I'm having crazy problems here. Got to about 20 micrograms per deciliter, where 80 would be the legal limit, at least in New York State. 3 months after the procedure, the same amount of alcohol gets to, let's say, 60 milligrams per deciliter. And 6 months after, they go above the legal limit of alcohol, drinking the same amount of alcohol each time. And this has got a lot of stuff on the slide, I guess, but this is looking at 8 women, or eight females. They have Roux-en-Y 1 to 5 years ago, 9 women awaiting a Roux-en-Y. They give them all two standard drinks. The dark circles are the people who have had the Roux-en-Y. They go up to a much higher blood alcohol level than the people waiting for the Roux-en-Y. They also feel much more drunk. In the bottom panel are the people who are acting as their own controls. This is before they have the operation. After, you can see they get that higher level of alcohol. So it turns out that in many of these long-term studies, and there's a huge amount of literature on this topic of bariatric surgery and its effect on alcohol, but it turns out that people, looking at people who have had bariatric surgery. And if you look at the difference between year 1 and year 2, from year 1 to year 2, how many people develop alcohol use disorder? And you can see with the Roux-en-Y that goes up about 7 times, and with the sleeve gastrectomy about 8 times, just by having the surgery, where they now meet criteria for alcohol use disorder. There was a recent publication, I didn't have enough time to make slides. Shannon, you may know about it. It came out of the VA, large study with bariatric surgery showing exactly the same thing, that there's about an 8 to 10% risk of developing alcohol use disorder in people who didn't have the alcohol use disorder prior to the surgery. So what is special at the 2-year mark? Because this doesn't happen right away. This happens a year or 2 later. And probably, when they first have the surgery, people are trying to be healthy, and there's some evidence that they decrease drinking maybe initially. They're also losing weight. They're feeling a little bit better about the losing weight. But after 2 years, people no longer lose a lot of weight. They also, as they're losing weight, socialize more. And as they socialize more, they're more in environments and bars and parties where there's more alcohol available. So that's kind of what's going on with the 2-year mark. The other thing to keep in mind is this is looking at mental health conditions among patients seeking and undergoing bariatric surgery. And there are relatively high rates of a lot of these psychiatric problems. It's a substance use disorders, 3%. And, depression, anxiety, have relatively high rates as well. So this is a population that comes in with some comorbidity. So the 24-year-old man, he said, I think I'm substituting alcohol for food. Yeah, alcohol for food. And that would be one way to look at this. Why does this happen? But it's really not the correct answer, because if it were a substitution for one addiction for another, why would it be delayed for 2 years? Why wouldn't it just happen right away? And why would it be procedure dependent? And this also occurs in people who have gastrectomies, not for bariatric surgery, for cancer, or in the old days for peptic ulcer. They also have the same problem. And in rodents, if you do a Roux-en-Y procedure on a rat, they will drink more alcohol after the procedure than they did before the procedure. So the answer here is a change in pharmacokinetics and pharmacodynamics. And this explains why the Roux-en-Y and the sleeve gastrectomy are different than the laparoscopic banding, because you don't take the stomach out in the laparoscopic banding. The stomach is really the first place that alcohol is metabolized in us, in humans. And there's gastric ADH, alcohol dehydrogenase, in the stomach lining, and that's the first place alcohol gets metabolized. Some of you may remember the first H2 blocker, cimetidine. Does anybody remember that, cimetidine? There was a period of time when people were coming in and asking to be placed on that because the cimetidine blocked gastric ADH, and people found out about that, and it became kind of a thing, at least in New York City. So what do you get? You get increased absorption of the alcohol, because now the alcohol is going right into the small bowels, right? Which is where it gets absorbed, not in the stomach. You're getting a higher maximal concentration, and it's happening earlier. So this is characteristic of all addictive drugs, right? A rapid onset of action makes things potentially more addictive. The other reason that don't think it's substituting one addiction for another is you don't hear about other addictions occurring in this bariatric surgery, like opioids or cocaine. So as I was trying to put this all together in my own head, I thought about the cocaine analogy between intranasal cocaine use, which was so common in the 70s. And yes, there were problems, but nothing like the crack problem in the 80s, when now the cocaine was getting into your brain in 8 seconds, as opposed to much longer with intranasal. And that's what's happening with the alcohol. It's getting in much more quickly. It feels different. There are some predictors of who might be more susceptible to this. Again, you've got to have the stomach bypassed or removed. Male have Males are more likely to get this, even though women have more weight loss surgery, younger age, family history, more alcohol use pre-op, tobacco, illicit drugs. Don't know why ADH is one of the factors, but it is. And again, the more weight you lose, sometimes the more socialization you're having, the more exposure to alcohol. So this is very old data from 1989, and this is just showing, this is showing patients who've had gastrectomy for peptic ulcer disease. And it's showing in the left lower panel, giving alcohol PO to a person, and then putting a tube in and giving it to them in their duodenum, or giving it directly into IV use. And you can see that giving it directly into duodenum closely approximates IV use. This is in people who don't have obesity. So key take-home points on this bariatric surgery. New onset alcohol-related problems occur in about 10% of people with weight loss surgery, more likely with the Roux-en-Y. Some people decrease their alcohol intake. The alcohol intake in alcoholism problems increase over time, usually about 2 years after. So we should inform and monitor all weight loss patients about the risk of alcohol use disorder. And I want to thank Alan Galipto, who first brought this to my attention. I'm wondering if any of you have seen people in your rehab or your detoxes coming in for alcohol who sort of had weight loss surgery, but you might not have thought that that was related. No? All right. There are supposed to be a certain percentage of people. Yeah, yeah, I've seen it. Yeah. Yeah. Yeah, yeah. Now that I realize that anybody that comes in and says they had gastric surgery, you know, we ask them how this all worked out. Okay. So, yeah. Yeah, more common in males than females, even though females have more weight loss surgery. Yeah, they do. That's true. The drink for drink, they get a higher blood alcohol level. That's what the literature says. Okay, all right. Depending on what? Yeah. Okay, I mean, and this is another reason why people say, if you don't want to get too buzzed from alcohol, eat something, you know, when you drink to slow down the gastric emptying. And here you have no gastric emptying, boom, right in, right? Yeah, okay. All right. So we're doing okay, right? Yeah, good, okay. So here we have a 38-year-old female with alcohol use disorder. She's admitted to the inpatient rehab following an alcohol detox with chlordiazepoxide. This is 6 years ago. Hard to believe. It seems like it was a couple of days ago. She says she never felt happy, always anxious, low self-esteem, physically abused by her father. Mother ignored that. She was raped when she was by a stranger on a street while intoxicated with alcohol. She's tried other drugs, but she likes alcohol the best. So in those days, our rehab was a locked unit, and we had visitors that could come in once a week on a Sunday. And she was admitted, I think, on a Thursday. So it was either a third or fourth day in the rehab when that Sunday came. And then she had a visitor come in on that Sunday. We had started her on gabapentin, 300 milligrams TID for MAT, for alcohol use disorder. So just want to make sure you got this straight. Visitor comes in on Sunday. On Monday, at about 9 o'clock in the morning, she has altered mental status. And she's sedated, somnolent. A rapid response is called. Her O2 sat was not too bad. Glucose was okay. Blood pressure, things were, you know, not alarming. And after she was given an IV and hydrated a little bit, her mental status improved and she stayed on the unit. Okay. We did a urine drug test at that time. Again, those were the analytes that we had, and they were all negative. We often think that a visitor might have brought in pills or something else and that the patient may have taken it. But we did a blood alcohol level on her, and the blood alcohol level was 312. Again, where 80 would be, at least in New York, the legal limit. So your job is to figure out what happened, where did the alcohol come from? You know, I don't hear that well, so if somebody says something, if somebody could repeat it and yell it out, huh? Visitor. We always think the visitor's bringing stuff in, although we search them a little bit, but it wasn't a visitor in this case. No. That's it, bingo. Hand sanitizer ingestion. So these are our hand sanitizer dispensers in the hospital. And when you open them up, there's this bag of hand sanitizer, plastic bag of hand sanitizer inside. And these are wheeled around by the housekeeping people. And I guess it was open or she knew about it. And she grabbed it, probably took one out of the maintenance cart that the people have there. And what happened is that we found this empty hand sanitizer container with a bite hole on the top under her bed after this rapid response thing happened. And turns out she had consumed the entire contents, squeezed it all out. Now, what I did not know about hand sanitizer until this case is that hand sanitizer is almost 63% ethanol, which is 125 proof. Somebody once explained to me why you need to know the proof and the percent, but I forgot what it was already. The proof is always twice the percent. Now, 63% ethanol is a lot. If you need more proof, you can go to Staples and get 140 proof, 70% alcohol. But the drinks that you drink with alcohol don't have that much alcohol in them, you know? A beer is 5%, wine about 13, whiskey 40%, Southern Comfort 50. So this is more than the alcoholic beverages that we drink and think about, you know, as alcohol. So Listerine has 25% alcohol. Now, I bet you very few people knew that vanilla extract has 35% alcohol, which is a pretty reasonable amount. And NyQuil and other cough syrups sometimes have alcohol. So, you know, as this case is going on and I'm putting it together and I'm thinking about presenting it, I'm like all hand sanitizer now all the time while this is all happening. So I see the vanilla extract, and then it's just amazing. This was in 2019. A woman gets pulled over in Connecticut. I'm sorry, she gets pulled over in Connecticut for driving under the influence. Police thought she was weaving in and out of traffic. And the officers say they found several bottles of pure vanilla extract inside her vehicle. They say they detected an odor of vanilla on her breath. Her speech was slurred and she was unable to answer basic questions. So I thought that was an incredible coincidence. So when we went back to talk to her after we realized what had happened, she says she's for a 5-year history of drinking hand sanitizer in healthcare facilities. She said it's like vodka, but a little bit stronger. She would drink sanitizer to alleviate withdrawal when she was in a healthcare facility. She doesn't have any hangovers. She says, I also drink Listerine from time to time. And she has required ICU admission and intubation in the past from excessive alcohol intake. So there's a literature on hand sanitizer, not as big as on the bariatric surgery, but there is a literature. The rising incidence of intentional ingestion of ethanol-containing hand sanitizer. I have that author's name in red for a reason I'll show you later. And the date is 2012 of the article, a long time ago. And this you can't read, but they found 14 cases of intentional ingestion. And basically this happens in people with alcohol use disorder and psychiatric illness. Those are the two groups you find this in. You get incredibly high levels of alcohol. In one case, 700 milligrams per deciliter. That usually is a toxic level enough to kill somebody. And there was one death in this group, in the case series of 14 patients. So then they have this slide, which is also kind of busy, but I want to walk you through it because I want to show you something. In the top panel, we have hand sanitizer ingestion, and this is by age group. So over here is adults, here are teenagers, and here are children under 6. And it turns out that the most exposures to hand sanitizers occur in children under 6. In that group, almost all of the exposure is accidental, not intentional. In the teenage group, we have more intentional. Teenage group is about 23% intentional. And in people over 20, again, about 22% is intentional. So that means most of it is unintentional. And I'm looking at, and the bottom panel just shows that in most cases, the medical outcomes were relatively benign. A few people had to be hospitalized. Most people got better in the ED and went home and didn't have a big medical problem. But I was stumped as to how there could be so many unintentional exposures in adults, right? In children, I kind of get it. But in adult, how do you have unintentional exposure, right? So I didn't understand that. So I decide to write an email to the lead author of the article. And I'm doing this in 2019. The article was published in 2012. And I'm writing to that guy, Sufredi, and I'm writing this at 6:30 p.m. And I'm asking him, I had a problem with understanding why adults would have so much unintentional exposure. Doesn't make much sense to me, right? Right. Now look at this. I get a response from him in about 13 minutes. And I wish I could read it, but I can't. He works at the NIH. He says, I'm making rounds now. I'll get back to you as soon as I can. But he said, I believe the reason is that most of those adults with unintentional exposures had some form of developmental disability. And he says, I hope that helps. And that did help. That becomes understandable now. But I just thought, hey, to get a response in less than 15 minutes from an article that's 5-6 years old, just incredible, right? Huh? Incredible. So what about healthcare providers, especially nurses, who are told to wash their hands after every interaction? We have the sanitizers all over the place. The question here is, can you have a positive test for alcohol, particularly if you're being monitored either as a physician or a nurse by the Committee on Physicians' Health? Can you get a positive just by using a lot of hand sanitizer? So here's the paper. They get 11 subjects. They don't no alcohol ingestion. They put them in a conference room. They cleanse their hands every 5 minutes for 10 hours each day for 3 days. That's 120 cleansings each day. 62% hand sanitizer, and they leave urines there in the morning and the afternoon. And then they check for 2 different metabolites of alcohol, ethyl glucuronide and ethyl sulfate, because those are the metabolites that will give you a much longer picture than just looking for alcohol, which is metabolized quickly and is usually out of the urine by, let's say, 12 or 18 hours. So it turns out that if you use ethyl glucuronide and you use a cutoff level of 500 nanograms, which is the standard cutoff level, there were many people who went above that 500 nanograms with this intense use of hand sanitizer, whereas with the ethyl sulfate, no one did. So their recommendation is to use ethyl sulfate, but to be aware, if you're a healthcare provider being monitored, to go easy on the hand sanitizer. Oh, and there's a new test, which I haven't used or really been aware of, called PEth, phosphatidyl ethanol, which can now give you a detection of 3 to 4 weeks, looking at red cells and how the alcohol has affected the red cells. So, and then again, this is for people who are being monitored under very careful circumstances. You have to know whether they're drinking or not. So you guys know Wells Fargo Bank. They had this big scandal with everybody was selling things that people didn't need. And the lady there who worked there, who was going crazy with this, she said, from that point, I began to drink the hand sanitizer. She got the quote of the day in the New York Times. I went to the bathroom and took a drink of some hand sanitizer. And that was because they were making these folks sell things to customers that they didn't need. And it really was a big scandal a couple of years ago. So like with everything else, then there were hand sanitizers that didn't have ethanol in them, but they had methanol. And some of them are coming from Mexico. And methanol is that wood alcohol where if you ingest that, that's a big problem that comes with that blindness and the formaldehyde, the formic acid, the toxic alcohol. So that became an issue. It's amazing because you come here to give a talk on April 8th, and then you see something on April 1st, and you say, wow, that's really good. And this must be like Walt Disney, voluntary recall of Mickey Mouse hand sanitizer due to presence of methanol, and the Mandalorian hand sanitizer due to the presence of benzene. So a lot going on with hand sanitizer. And then, kids have been using a lot of it now, and I think they have to reach up sometimes. And there were a couple of cases where they got it in their eyes. The next slide is an ugly slide. Don't look at it. They got bad eye injuries from it. So here's a good story. New York City, 2017, I think. Yeah, 2017. Subway car, all full of SWAT stickers. They got a bunch of people in the car who have Purell hand sanitizer in their pocketbooks or their pockets with tissues, and they're able to wipe off all the SWAT stickers with the hand sanitizer. And look, there are times when you just don't really need any more hand sanitizer. So I have one last little case here, which I was going to do in the next workshop, but we'll do it here since I have time, okay? So did she or didn't she? What will the clinician predict? So we had a 71-year-old female coming in requesting outpatient opioid detox. We do outpatient ambulatory opioid, quote unquote, detox or withdrawal management with either methadone or buprenorphine, depending on which the patient prefers or wants and all of that. The woman was domiciled, retired. Her last opioid detox, she said, was several years ago. And this woman was being prescribed oxycodone IR for chronic low back pain, 20 milligrams 4 times a day. She said she claims mild withdrawal when the oxycodone wears off. Then she says she uses heroin by skin popping to alleviate the withdrawal signs and symptoms from the withdrawal from the oxycodone. But she claims no misuse of the prescribed oxycodone. She wants to continue with the IR oxycodone, but not use heroin. And so she came in to quote unquote be detoxed from the heroin. We're going to stay on the oxycodone. She had a COWS score of 3, so on a couple of other medications. And we had a new person working there that day, and I was not called. And so this case, of course, makes no sense the way it's being presented, but the person said, okay, and enrolled her in our outpatient detox and gave her 20 milligrams of methadone for this heroin detox, even though she was on the oxycodone. Okay. So then they present the case to me, and I realized that, this is not reasonable to detox somebody with methadone when they're taking oxycodone. So I called her up and I said, hi, I'm Dr. Salsitz. You were just here today. Do me a favor. I want you to bring in your bottle of oxycodone that you have when you come in tomorrow for your next dose of methadone, and bring it in with all the tablets. And she says, okay, I'll try. So which of these 5 choices do you predict? The patient will not return for the next appointment. She'll return and forget to bring the oxycodone. She'll return and claim the partner throughout the oxycodone. Return and have the correct pill count. Patient will return with empty bottle or few oxycodone pills. So I wish we did have the ARS system here, but we don't. So I guess there's no way to do it except to kind of go on, right? Yeah, okay. But those were the choices. So she did have the correct pill count, which I'll show you when I've done this case in other venues. The physician clinical support system has roundtables, and I presented the case there, and only 8% of the participants thought she'd come in with the correct pill count. Everyone else thought there'd be something wrong, but the biggest one was return and forget to bring the oxycodone. So only 8% of people who do addiction medicine thought she'd come in with the right count. And then I did it for the New York Society of Addiction Medicine. And in that case, 13% of the attendees thought that that was going to be the correct choice. And then I did it for the Addiction Club, which we have at Mount Sinai, and we got 21% thought that it would be the right amount. And then I did it for the Mount Sinai medical students at an ethics conference, and 23% thought she'd come in with the right amount. So everybody thought something was going to be really off. So this is what our PDMP, is that what you call it, a PDMP in North Carolina, PMP? Yeah. For some reason, it's called Ice Stop in New York. I don't know why. I looked her up, and she's getting these oxycodone pills every month. Do I have that? Yeah, one prescriber is prescribing them. And when she came in initially, we did the urine toxicology on her that we were doing at the time, positive for opiates. That went along with the history of heroin use that she said she was doing. She was positive for methadone, which was a surprise because there was nothing about methadone mentioned in the history. And we didn't have oxycodone on our urine toxicology test at that time. So I sent it out for oxycodone confirmation, and the oxycodone was positive, and the oxymorphone was positive in a similar way to the morphine hydromorphone. Oxymorphone is a metabolite of oxycodone, and it's at a lower level. So she was taking the oxycodone. So she came back with the exact count. She said, I use heroin as a means of not using more than 4 oxycodones a day. When I don't have the heroin, I sometimes take more than 4. When I'm running out early, I use heroin or I buy illicit methadone, and I buy it from somebody in an OTP, opioid treatment program. So we discussed the options with the patient, prior history of opioid use disorder, methadone maintenance treatment, understands that a detox. She knew that this made no sense on 80 milligrams of oxycodone. Chronic pain masquerading as opioid use disorder, I think. We told her maybe she should enroll in an OTP and could use IR oxycodone for breakthrough pain. She didn't want buprenorphine. Asked the prescriber to switch to an ER formulation rather than IR, increase the dose. You mentioned hyperalgesia. We thought maybe that was part of it, and the non-pharmacologic treatment. So to me, the moral of the story, and I try very hard to practice that way, is everybody's innocent until proven guilty. Otherwise, you drive yourself crazy.
Thank you again to Dr. Salsitz for that presentation. If you'd like to see the slides he referenced, you can find them on addiction-medicine.org. That's also where you'll get information on our Addiction Medicine Conference in Asheville every spring, and the Addiction Medicine Essentials Conference held virtually in the fall. Both events are put on through partnerships with the North Carolina Society of Addiction Medicine, with funding from the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services, the North Carolina Division of Public Health, and the Substance Abuse Mental Health Services Administration. Thanks for listening.